It's time for Back to Life, brought to you by Southwest Spine and Pain. A 30-minute conversation with their board-certified physicians about how to live life again, pain-free.
And now here's the host of the Southwest Pain and Spine Back to Life show, Dr. Rick O'Bray.
All right, so today I thought what we'd do is review a little bit about what we talked about last time and then kind of go on to some new topics and review that with everyone. This program is designed mostly to be educational for patients, and we're approaching this from a patient's perspective. So patients can get an idea of some of the common conditions that can be treated and how those treatments can be performed. So last week, again, we talked about stem cell therapy. I want to review a little bit about what we talked about. And again, that radio program will be available to patients on our website. So if they have an interest in reviewing that, then they can and hear that full program. But stem cell therapy, we discussed the three main types of stem cell therapies that are occurring, namely tissue allograft injections or placental or umbilical cord injections. They all fall under those tissue allograft injections. We also talked about bone marrow or autologous stem cell injections, went into some detail about some of the literature that's available and some of the studies that have been done. We also talked a little bit about adipose tissue stem cell injections. Some of the key factors when considering stem cell injections is to make sure that whoever is performing the procedure is someone who's trained to do both interventions, as well as the company providing the product is FDA approved and following FDA guidelines. The biggest risks associated with tissue allograft injections, like we talked about, is really, one, safety of the procedure being performed. Is it someone who took a weekend course and has done 5 procedures, or is it someone who's done 25 to 30,000 procedures? Also, key is to make sure that the product being injected is safe, and that primarily falls on the manufacturers, and those are regulated by the FDA very closely, but that product should be monitored, and the companies that provide that product should be receive periodic audits from the FDA. And that's an important fact, because one of the risks associated with tissue allograft injections is infection. So those tissues, you can contract infectious disease from those if they're not screened properly. You want to reduce that risk as much as possible. And one of the things we talked about, autologous or bone marrow stem cell injections, is that they can be helpful. The procedure does require aspirating bone marrow from a patient, usually from their hip. But again, that is generally not painful when performed by someone with experience, and those can be effective, very similar to adipose types of injections. And then one of the keys to any patient considering a stem cell injection is to make sure they understand the benefits, the risks, alternatives that may be involved with those procedures, a process that we call informed consent. And anyone performing those procedures should have a very detailed conversation with those patients about informed consent, so they understand benefits, risks, as well as alternatives of those types of procedures. And that's true for any medical procedure that is performed. All right, so today we want to talk a little bit about some of the new therapies that are being made available to patients in St. George and the surrounding areas. And one of the things we're really excited about is something called the Superion Vertiflex procedure. So what is the Superion Vertiflex procedure? One of the most common things we see as a practicing spine and pain specialist is something called spinal stenosis. So spinal stenosis literally means narrowing of the spine in the spinal canal. So as we age, our discs tend to degenerate. We get arthritis in the back, and the central canal where all our spinal cord and our nerves travel through tends to narrow. When that spinal cord narrows, it can put pressure on the nerves, it can put pressure on the spinal cord. And what that does is it alters the way the nerves conduct signals and can affect how you walk, it can affect how you stand. Generally, patients that experience symptomatic spinal stenosis kind of walk in a slightly bend forward position at their waist, and they tend to lean forward and like to rest on things. So one of the common places I see a lot of spinal stenosis is at Costco. So I take my kids, we go to Costco, we're shopping around, and I can usually tell who has spinal canal stenosis because they tend to lean forward a little bit and they like to push the cart. Because when they lean forward and they push the cart, they're able to travel a lot further than if they were walking on their own. So what are the symptoms that we see with spinal stenosis? Well, one of the things we see is something called neuroclaudication. So what does neuroclaudication mean? Well, neuroclaudication means literally heavy nerves. So when someone has neuroclaudication, the longer they walk, their nerves tend to feel funny in their legs, and they can ache, they can feel tired, they can lose sensation and get numb. And when they sit down and rest, the symptoms go away. So they walk for a while, their symptoms come on, usually in a very predictable fashion, half a block, 20 feet, depends on the patient. And then when they sit down, they feel better. Pain goes away, and they're able to go and get a walk again. The problem is when they get up and they walk, they get the same symptoms again. So that's because with stenosis, those nerves are being compressed as that patient is walking. And as that occurs, those symptoms come back. So what can you do for neuroclaudication? How can you treat it? Well, you can treat it by kind of strengthening the core and stabilizing the spine. That can help. So physical therapy sometimes can be effective for that. Injections can provide temporary relief. So for pain that goes down the legs, lumbar epidural injections can be effective. Usually they last for about 3 to 6 months, sometimes longer, sometimes shorter. What else can you do? Well, for moderate to severe stenosis that doesn't respond to physical therapy and doesn't respond to interventional therapy, they're generally referred for surgical intervention. So what does that entail? Generally for for stenosis patients, they do something called a laminectomy. So what does laminectomy mean? Well, it means they go in, they take out the back part of the back called the lamina, they remove the bone, and that opens the canal. But that's a relatively invasive surgery requiring hospital stay, recovery, and then extensive rehab to kind of get back to normal strength. So historically, that's really what was offered for patients with moderate to severe stenosis that was refractory to the treatments that we discussed. Recently, a new therapy has been developed for patients who have moderate to severe spinal stenosis with neuroclaudication, and it's something called the superior vertiflex procedure. So what exactly is the superior vertiflex procedure? Well, the superior vertiflex procedure is a minimally invasive surgery that actually places a small device posterior to the spinal lamina in between what are called the spinal processes. And what that does is that opens up the spinal canal without having to remove any bone, without having to undergo a major surgery. This can typically be performed in an outpatient surgery center, and it takes about 20 to 30 minutes to perform that procedure. It is covered by Medicare, so it is insurance covered, and they have a very good study which based on several hundred patients and up to 5 years of follow-up, where they performed the procedures, followed the patients, and the patients did very well, up to 70% response, a positive response to that surgery. So that procedure has been a pretty significant advance. Now, it's not recommended for severe spinal stenosis patients, but for moderate to severe spinal stenosis patients that are symptomatic with that neuroclaudication can be very helpful for them. So how do you tell if you're moderate to severe or severe? What are the symptoms? How do they change? Well, generally when patients have severe spinal stenosis, a lot of times they can have changes in their bowel or bladder function as well. So it turns out that if that stenosis gets severe enough, it can actually encroach on the nerves enough to where they don't function, and not just the nerves to the legs, but it can affect the nerves that go to the bladder. It can also affect the nerves that go to the bowel, and there can be problems with controlling bladder and bowel function. So that generally is what we see with severe stenosis. If you're having questions about those symptoms, you can usually talk to your physician or see a spine specialist, and they can explain and walk through those with you and do a detailed history and physical and make the determination about how severe your symptoms are. Generally, advanced imaging such as MRI or CT is also required to make the diagnosis of severe spinal stenosis. So how is the surgery performed, the minimally invasive superior vertiflex procedure? Well, it's basically if a patient is felt to be a good candidate. So who are those patients? Well, someone who has pain when they walk, goes away when they sit down, gets better when they lean forward, and is usually predictable. So every time they get up, they walk, they get the symptoms of heaviness in their legs. Most commonly, it's down the posterior legs. Those would be patients who would be candidates for this procedure. And generally, you can find these patients because when they get the pain, they try to lean over a little bit to open up that canal and relieve pressure. So those patients, when they see a specialist, they are evaluated and determined to have neuroclaudication associated with moderate to severe spinal stenosis. Then they can be consented for that surgery. And what it requires is patient generally lies on their stomach, and through an incision about 3/4 of an inch long, So less than an inch of incision, you can go down and through a series of steps, you can place this device. Usually takes about 20 minutes to place the device. And then there's a tiny suture that closes the incision in the skin and a small bandage. And usually patients go home within about 30 to 45 minutes after having the surgery. So the nice thing about it is you take a surgery that generally can be a traditional laminectomy, can require at least usually an overnight stay in the hospital with several weeks of recovery and sometimes several months to get strength and core back. And the nice thing about the superior arm procedure is it doesn't require any surgical resection. There's no resection of bone. There's no resection of lamina. And for the moderate to severe patient that doesn't have the symptoms of severe stenosis, it can be a really nice treatment to allow them to continue with the normal activities of life without having the pain that they previously had. So that superior inverted flex procedure is something that's being offered now. I had the good fortune of performing the first superior inverted flex procedure in the state of Utah, and that's has been a very rewarding performing these procedures for patients. We've been doing them for about a little over a year now, and have treated up to somewhere between 30 and 40 patients at this point, and we've been very pleased with the results we're seeing. So that's something that's new. That's a treatment for a very common condition, spinal stenosis, which is back pain with leg pain that typically involves pain that radiates down the posterior legs. So that's something that can be very helpful. So what else? Interventional treatments or minimally invasive treatments that patients can be helped with. One of the more common things we see as practicing interventional specialists, interventional spine and pain specialists, is something called compression fractures or a vertebral compression fracture. So what's a vertebral compression fracture? So as we age, our bones tend to weaken a little bit, and they're not as strong as we were when we were 18. And occasionally, particularly in the winter months, we may slip on the ice and we fall on our behinds. And when we fall on our behinds, there's a compressive force that occurs in the spine. Well, the bones that provide the major structural support for the spine are the vertebral bodies. So the vertebral bodies are really the scaffolding and the weight-bearing portion of our spine. And in between the vertebral bodies are the discs. Well, when we fall and we apply a very strong axial load, those vertebral bodies can compress and they fracture, just like any other bone. They can collapse. And when that happens, they get very painful fractures called vertebral compression fractures. Vertebral compression fractures affect over 600,000 patients in the U.S. every year. And they're very common, and they can be extremely painful. So generally, a patient will have a fall, they'll have severe pain, they have a difficult time rolling over in bed, they have a difficult time getting up in bed. If they lean forward and even bend a little bit, it can be severe pain. And when I say severe pain, I mean 10 out of 10 pain. Catch your breath, can't breathe, can't hardly move type pain. Generally, a lot of these patients will go to the emergency room because the pain is so severe they can't function. So they go to the emergency room, they'll get an x-ray, and they'll diagnose the fracture. Sometimes they'll get advanced imaging such as MRI and CT, and they'll see the compressed vertebral body, and they'll be able to diagnose that they have a fracture. So these patients a lot of times are hospitalized for a matter of days, sometimes weeks, to try to treat these fractures and control the pain. Well, one of the things that you can true for these fractures, so some of the fractures will heal on their own. And if the pain is generally less than 5 out of 10, and the patient does well, we'll brace these patients. We'll allow them to wear a back brace. We'll get them fitted for a customized back brace that provides some support and takes some pressure off their collapsed vertebral body, and these fractures can heal. For more severe fractures or fractures that are more painful, and they don't tolerate bracing or the bracing is not very effective, then there's another treatment that's available, and it's something called a kyphoplasty. Let's talk about what a kyphoplasty is. So when you fracture your arm, say you fracture your radius or your ulna, generally what will happen is you'll take an x-ray, you'll see the fracture, and the surgeon or orthopedist will take the fracture and try to realign the bones. Once he's realigned the bones, then he'll put a cast on it. And by putting that cast on, it allows the bone not to move. And it's very important for that bone not to move to facilitate healing of that bone. So you put the cast on, usually 6 to 8 weeks, that bone heals, you take the cast off, and the bone is not as strong as it once was, but the fracture is healed, and it allows that deformity to be corrected. The problem with a vertebral body compression fracture is you can't put a cast around the chest. You put a cast around the chest, the patient can't breathe. It's very difficult to try to put a cast around that compressed or collapsed vertebral body because you can't get in there, because the fracture is in the back of the spine. where it's very hard to get a cast around that because of all the surrounding soft tissues, lungs, and so forth. So what you can do with this kyphoplasty procedure is it's an image-guided procedure, meaning we use X-ray, real-time X-ray, and we take a small needle and we advance that needle through the soft tissues of the back into the bone, and we actually put that needle right down into where that vertebral body is fractured. And we do that with image guidance to make sure we know exactly obviously where we're putting that needle. Once that needle is in the vertebral body, there's a series of steps, one involving a balloon. So you actually inflate a balloon and you try to restore the height of that vertebral body. So one of the reasons we shrink over time is a lot of times we'll have these fractures, we're not aware of them, and we lose height. So for an acute or subacute fracture, we can go in with that needle, we blow up a balloon, and we try to restore the height of that vertebral body. And all this is done using X-ray and image guidance at low-dose X-ray, so it's not a significant amount of radiation to the patient. Once we blow that balloon up and we restore the height, we pull the balloon out through the needle, and we put a specialized instrument that delivers bone cement into that vertebral body. So how does that work? Well, bone cement, it turns out, has been developed to where it's almost like a toothpaste type consistency. It's a combination of polymethyl methacrylate. Anyway, what that is that's a cement that is liquid at room temperature, but once it gets inside the body, it hardens, almost just like what it says. It's cement. So it hardens inside the vertebral body. Well, once you establish the height using the balloon and then you inject that bone cement into that vertebral body, when that bone cement hardens, it creates a cast on the inside of that vertebral body. Now, the nice thing about having a cast inside is that the bone no longer moves. So most of the pain associated with the fracture is associated with movement. So if you could sit in your bed for 6 months and not move, your fracture would heal and you wouldn't have any pain. The problem is every week you sit in your bed and don't move, you lose bone density and you lose muscle mass. You know, recently having surgery on my ACL, my anterior cruciate ligament in my right knee, I learned how significant this can be. So after the surgery, I didn't move much, and it seems like my quadricep, my hamstring muscle in my right thigh shrunk about 50%. It was dramatic how quickly I lost muscle mass in strength in that right leg. That's the same thing that happens when we get these compression fractures. Patients don't want to move because it hurts, so they'll lay in bed and they'll sit there, sometimes weeks at a time, and let that fracture heal. The problem is if a patient is not getting up and moving around, every day they're sitting in that bed and not moving, they're losing muscle mass and they're losing bone density, which does two things. One, it makes it more likely they're going to fall in the future and have more fractures, and it may be your back, it may be their hip, it may be their wrist. The other thing it does is they lose all their muscle mass. And when you're 44, which is my age, I can gain that muscle mass back a little easier because I can go and do physical therapy and ride my bike and all those things. But when you're 80 and you have a compression fracture, it's much harder to get that muscle mass back. So one of the reasons we tend to treat these compression fractures very quickly is because we want to maintain patients' muscle mass. We want to maintain their bone density to try to avoid some of the complications that can occur from these fractures. And that's a big deal. There was a study that was done some time ago that looked at morbidity and mortality associated with these fractures. What does that mean? They're looking at how patients do. Patients that get these fractures that are not treated, how well do they do over time? Well, one of the things that was very surprising that was shown with these fractures, and when we have these fractures and we don't treat them, the mortality and morbidity associated with those fractures is similar to a hip fracture. So you can't imagine someone having a hip fracture not having that treated, right? Makes sense. Can't hardly walk, can't move until that fracture is treated. But the morbidity and mortality associated with these compression fractures is as high, or if not higher, than the morbidity and mortality associated with a fractured hip. So that was pretty shocking. And most of that is because when patients get these fractures, they don't move. They stay in bed and they atrophy very quickly, which makes them much more frail. And it's very hard when you're older to get that muscle and bone density back. So compression fractures. So what does the patient have? What are the symptoms associated with this? Because it's important to be able to understand what these symptoms are and to get appropriate care for these patients. Generally, it's severe back pain associated with a fall or coming down hard on your backside. When that occurs, sometimes patients will feel a pop or they'll feel a crunch, but it's severe pain. And when you look at the back, patients get tenderness over that fractured vertebral body. So you can actually gently push on the back, and it'll be very painful because you're very slightly moving that fracture. And that's one of the ways physically, on the physical diagnosis, that we can diagnose this pain. So if you have a loved one or yourself and you have a fall and you have severe back pain that can be 8, 9, sometimes 10 out of 10, you're having a hard time moving, then there's a likelihood that you could have one of these fractures. And it's important to get it diagnosed early and treat it if necessary. Now, generally, this is, again, pain that's 8, 9 out of 10 that is refractory to treatment. If you fall and you have a little back pain, and it's less than that, it's probably not a bad idea to rest, see if it gets better in a couple of days, and a lot of times that will happen. But if it doesn't and the pain is severe, then again, seeking out treatment is important, because some of these fractures are not diagnosed and they're not well understood, even though they're extremely common. So we talked a little bit about a little bit of review of stem cell. We talked about the Superion treatment for lumbar stenosis. We've talked about treating vertebral body compression fractures with kyphoplasty. So we have a few minutes left here. One of the other things I thought we could talk about is a procedure that we do very common for treating another kind of low back condition called lumbar radiofrequency ablation. So what's lumbar radiofrequency ablation? Well, in your back, you have the vertebral bodies, which we talked about, that can fracture, but they're the structural support. There are two small joints on the back of your spine that are called the facet joints. The facet joints are cartilaginous joints that allow you to rotate right to left on your back. They allow you to lean back without your back, basically your bones disassociated from each other and falling apart. So they're stabilizers for lateral motion as well as extension in the back. Well, these little facet joints, just like any joint in your body, your knee, a shoulder, have cartilage, and that cartilage can wear out over time. And one of the most common causes of low back pain that we see is related to the arthritis associated with these facet joints. So the term we use is facet joint arthritis, or facet joint spondylosis is another term that kind of describes some of these features. So what do you do for this? How do you treat arthritis in these little facet joints in your back? Well, one of the ways you can treat it is, again, core strengthening. So if you're in a good yoga class, or you do Pilates, or you do physical therapy, and you strengthen your core, then that can help, because it stabilizes the spine, takes less pressure on the discs as well as pressure on the facet joints. But of course, even the most fit people can get arthritis, as we see with marathon runners and knee arthritis and so forth. So what can you do for facet joint arthritis, low back pain that occurs despite all the treatments, meaning physical therapy, rest, ice, heat, massage, as well as over-the-counter medications such as ibuprofen or Aleve? Well, one of the things you can do is this lumbar radiofrequency procedure. So how do these patients typically present? These patients present with low back pain right across the low back that usually does not radiate down the legs, and it's their kind of aching pain every time they stand. When they lean back, it gets worse. Sometimes it's improved when they lean forward, and it's also painful when they rotate side to side. I see this in a lot of golfers. They get a lot of facet joint arthritis because of that swing. The rotation of the swing can put pressure on the facet joints. So if those conditions, we diagnose those conditions for patients, and then what we do is we do a test injection. So we bring them in and say, okay, go get your pain to at least a 3 out of 10. They get their pain, say they come in, it's 4 to 5 out of 10. They say, yep, doc, it's there. We have them lay on a table, and we use a small needle, and we inject numbing medication along these facet joints, where the nerve that goes to these facet joints, along the path of the nerve. And by doing that, we essentially completely numb the facet joint. So if they're having pain associated with that facet joint, the pain will go away. They'll be pain-free. Now, the pain will last as long as that numbing medication's there, and that's typically anywhere from 2 to 4 hours. So if we can accurately diagnose the pain coming from the facet joint, then we know that's where it's coming from. We generally follow up that test injection procedure with a small needle that has a cautery tip that heats up that nerve ending and destroys that nerve ending. And then instead of having pain associated with that facet joint, the facet joint goes numb. And most patients are very happy to trade their pain for numbness. So that's another procedure called lumbar radiofrequency ablation, that there's very good evidence for that. There's been several national studies that have been done that show that it can be effective for treating facet joint-mediated low back pain. That's something we do commonly. We've done thousands of lumbar radiofrequency procedures as our practice. So we're just about out of time. I think we have about 20 seconds left. Again, I just want to say this is Dr. Rick Obrey. I'm a double board certified pain specialist, spine and pain specialist that works at Southwest Spine and Pain. And we offer minimally invasive treatments to treat common low back and joint conditions. Thank you very much for your time.
Join us for Back to Life every Monday at 5:30 p.m. here on St. George News Radio, where board-certified physicians from Southwest Spine and Pain discuss different alternatives to live life again pain-free. For more information, go to southwestspineandpain.com.